It's my great pleasure now to invite Dr. Padma. Um, Dr. Padmavati needs no introduction. Dr. Padma is the director of the Schizophrenia Research Foundation in Chennai. She's a wonderful researcher. She has done a lot of work in the area of schizophrenia, has held many international projects on various aspects of schizophrenia, has published widely, is a very astute clinician. And what is very interesting is that she has a lot of interest in looking at the medical health issues in people with schizophrenia. I also know for a fact that she's actually done a certificate course or a diploma in diabetes, so that she can handle her patients much better and doesn't have to keep referring them to physicians. And I think this is a very important aspect, because we all know that people with mental health problems often just view their psychiatrist as their physician. They don't like to go to other places. We know that people with psychiatric problems have 10 to 20% higher morbidity. The access to medical care is poor. Even when they have access to care, there is often stigma, and physicians may not take them very seriously, so they don't get the kind of care that they should. In fact, in 2018, November, the WHO, based on these findings, released a very good set of guidelines for physicians and for psychiatrists on how to handle physical and medical health problems in people with schizophrenia, because of all the challenges that we have. We know that there may be drug interactions. We know that there are lifestyle issues which lead to medical problems in people with mental health conditions. We know that even conditions not just like the metabolic syndrome or diabetes or hypertension, but we know that conditions like cancer have been found to be higher in particularly in women with schizophrenia. So there are a range of issues which are extremely important, and I can't think of anybody better than Dr. Padma who will talk to us. So over to you, Dr. Padma.
At this juncture, I am very pleased to honor our speaker, Dr. Padmavati Madam. With the respect, I present this memento on behalf of CME Committee and IPS Southern, Madam. This will reach you on Monday, Madam.
Thank you. Thank you so much.
Thank you so much for your acceptance. Okay, Madam.
Yes, thank you. Thank you, Prabha, for a very kind introduction of what I would be speaking of today. Jumping from the enigma of what really causes schizophrenia, that was very beautifully elucidated by Ramya. And listening to her, one would think that, when I was a student 30 years ago, it's the same kind of conundrum that was there for schizophrenia that continues to bog our understanding of this whole enigmatic illness. But to me, as a clinician on the field, I'm going to take you through another journey of the complications of physical health in our patients, and what I see as a case for a psychiatrist's responsibility. As Prabha has said, very many times our patients don't want to go to physicians, but I think more often than not, our physicians, maybe friends of maybe our friends, don't really pay too much attention to our patients. So what is it that we need to do to understand this whole sphere of management of schizophrenia? Like someone had said earlier, it's easy to diagnose schizophrenia. Perhaps it's also easy to treat schizophrenia. And if you ask me, I think every one of us here would, if we were asked to talk about schizophrenia, we can talk about it for hours together. But on the other hand, when we're trying to look at the physical health of patients with serious mental illness, we are bogged down. So I'm trying to take you, I'm going to attempt to take you through a journey of looking at a very important aspect of our patients' lives, that is their physical health, Some of it has been caused by us. Some of it is a natural comorbidity of the patients. So the spotlight is on comorbid physical illness, and also what can we do? More importantly, what should we not do? Oh, there's a big list of physical illnesses. Tuberculosis or other infectious diseases, COPDs, sexually transmitted infections, hepatitis, obstetric complications, cancer, dental problems, cardiovascular diseases, and metabolic disorders like type 2 diabetes. And the list is never ending. I've just tried to put in a few of these conditions out here, but physical illnesses are a very important component of our patients' lives. What really got me onto this bandwagon of physical illnesses was some important, patient-related issues. There was a male 62 who was living in one of our residential facilities, chronic continuous course of illness, onset at the age of 21, and has since then been on drug treatment, essentially refractory to treatment. He was diabetic. He was diagnosed with diabetes since the age of 50. A recent ECG showed left bundle branch block. He was started on treatment for NCDs, and for 12 years he was on treatment of NCDs. So there were a lot of changes that were happening both in terms of psychiatric treatment as well as the treatment of NCD. But one morning he never woke up and nobody knew why. Obviously, he's had a cardiac arrest in the middle of the night and there was nothing we could. And this is a story that you've probably heard in a lot of people in the general population. But why did it bother me so much? This person was actually living in our facility for more than 20 years. And, sometimes you develop a kind of a relationship with our patients. And so it really bothered me that there was nothing that we could do to even identify or get him to treatment. He didn't give us a chance. On the other hand, I have a lady who's seeing me currently, 48, menopausal, chronic mood disorder, ill over 30 years, mixed state. So half the time, the several episodes happened during the year and she's never really reached a state where she was asymptomatic. She's also on mood stabilizers, in addition to a polypharmacy profile. Her body weight was 100 kilograms, which has happened over a period of time. A sedentary lifestyle, a very poor hygiene, prone to overeating, especially junk. She lives at home. Her routine screen picked up dyslipidemia. It picked up raised sugars and, of course, a raised HbA1c. She refused ECGs. She said, nobody should touch me. And she was afraid of being raped. And therefore, the ECG was refused. Of course, at one point, she did, talk about chest pain. And we had to forcibly admit her to the ICU. No question of asking consent and all at this point in time. That's another story. I don't want to go into the legal aspects of it, but we had to admit her to ICU with multiple coronary blocks. So if you look at physical health comorbidity in people with serious mental illness, there's an extensive body of literature right now. A lot of literature comes from India as well. The reduced life expectancy rates compared to the general population is definitely low. And more recent studies have shown that this range is actually widening. Where it was 10 to 15 years earlier, now they're even reporting about a 30-year gap in the life expectancy. And all this is because of avoidable and treatable conditions that have modifiable risk, lifestyle risk factors like sedentariness or tobacco use. And of course, a very important factor that is inequality to access healthcare and its treatments. Diabetes is more prevalent among patients. Some of it is caused by us. Some of it is a natural part of the illness, and I'll take you through that in a little bit. There's a greater risk of developing metabolic syndrome. And of course, ultimately, the leading cause of death in patients with schizophrenia or bipolar disorder is the cardiovascular disease. So here's an interplay of all these factors that I have talked about, leading to ultimately a cardiovascular disorder, which causes death in these, it causes increased mortality. So if you really try and look at what are the premature, why does premature mortality in serious mental illness occurs? Essentially, this was identified over a half century ago. And since then, we have still been struggling with this mortality. The leading cause of years of life lost in patients with mental illness are due to poor physical health, right? There was a time when literature talked about how suicide was the major cause of mortality in patients with schizophrenia. But now we are looking at poor physical health, which occurs as a comorbidity to psychiatric symptoms. Invariably, it's non-communicable disorders. And of course, in our country, infectious diseases do play a major role. Despite the increasing research in this area and the general advancements in healthcare, I mean, you have a lot more. The cardiovascular surgeon would talk about how methods of surgical interventions, interventional cardiology has improved dramatically over the last few decades. The kind of the physical health of our patients has really not improved. And who's responsible for this? Who also is responsible for this? There is a 1.4 to 2-fold increased risk in cardiometabolic diseases as compared to individuals without mental illness. And mortality remains high even after you adjust for behavioral risk factors like smoking, physical activity, or body mass index. The other concept that is extremely important to bear in mind is this multi-morbidity. It is an important risk concept. It is associated with functional decline, a worse quality of life, increased risk of premature mortality, and increased healthcare costs. So people in Scotland, in a study, there were significantly good number of people who had 2 physical comorbidities. And sometimes you had even 3 or more physical health comorbidities than the general population. So there is a gap in understanding the prevalence, the understanding of the prevalence and the impact of physical multi-morbidity in patients with serious mental illness. Metabolic syndrome. I mean, there's so much of work that's been done with metabolic syndrome, a pooled prevalence. In fact, this is our Indian study where we estimated that about 29.83% of the population with schizophrenia had actually metabolic syndrome as compared to the normal controls. The pooled prevalence in drug-naive patients was also high, 11.86. So something was working even before we started doing our bit for this physical health problems. In 78.7% of our population, we have found metabolic abnormalities. Obesity is about 30 times more. And if you look at the lipid fractions, they are also contributing to heightened levels of impulsivity, suicidality, aggression in persons with schizophrenia. In fact, Ramya actually shared her MD thesis with me, and she's found a very interesting rate of 54.7% in inpatients whom she had recruited as part of her. So I think I've got the year wrong. I think it's about 2014. But nevertheless, this is a phenomenal, and her thesis actually describes the reasons for why in Kerala and in inpatients, why there was such a high rate of metabolic syndrome. So I'm going to just take you through first tuberculosis, because that is something that we do tend to miss out. There is a higher prevalence of tuberculosis in patients with schizophrenia. Few studies only have been done, unfortunately, and if you look at it, most of them have been Western studies, inpatient settings mainly. In India, of course, we've found a lot of risk of exposure to TB has been because of homelessness, smoking, poor nutrition, and other comorbidities, including HIV. Also, interestingly, TB could be a cause of mental illness. Several of the anti-TB medications, particularly cycloserine, is known to be associated with mental health problems such as depression, anxiety, or even psychosis. So, another important take-home point is that TB also is highly stigmatized, as much as we would with a person with serious mental illness. So this often leads to patients stopping treatment for TB, increased alienation, and if they're also having mental health problems, there could be extreme forms of self-harm, including suicide. Now let's try and understand some of the risk factors. There is an increased recognition that even with people with psychotic symptoms without a full diagnosis have increased risk of various physical comorbidities. That means the physical comorbidities happen even before we make a diagnosis of mood disorder or schizophrenia. We've also known that high-potency first-generation antipsychotic medications appear to have a lower cardiometabolic risk profile than the second-generation antipsychotics. And we also know that the rate of smoking in those with schizophrenia is interestingly not elevated compared to the general population in some of the low and middle income countries, where smoking actually remains quite high in the general population. Now, this is a very busy slide, right? But I was, I had to show this slide because just the points that I would like you to take is, why is it so busy? It is busy because there are so many behavioral risk factors that affect all kinds of mental health diagnosis across the board, right? But let's just pay a little attention to, if you notice many of these little gray boxes that are there, just to tell you, I know it's a little difficult to read this slide, but then you do have conditions like post-traumatic stress disorder or even anxiety disorders. There is insufficient data to tell you that there could be behavioral risk factors. But if you look at a condition like bipolar disorder or schizophrenia, two interesting things is the sedentary lifestyle. People with bipolar disorder have a sedentary lifestyle of, they just sit for about 10 hours per day, especially if they are in the depressed phase. Patients with schizophrenia, even more. They sit at a place for about 11 hours per day. They consume, people with schizophrenia have a poor diet habit. They consume 400 calories more than the general population, and similar figures for the bipolar disorder. Also, the other important thing, if you look at as a risk factor, with poor sleep, even between episodes, people with bipolar disorder have elevated sleep-wake disturbances. People with schizophrenia have reduced sleep time and quality of sleep. So, although this is an extremely busy slide, what I'm trying to tell you is that there is so much of information available about behavioral risk factors, and therefore so much of scope for us to intervene. If you look at this, is mainly in terms of schizophrenia. Again, just to summarize the earlier slides, individual causes of increased morbidity and mortality: lack of exercise, obesity, alcohol misuse, smoking, unemployment. These are some of the individual factors. Of course, our second generation antipsychotics have done their bit to alter glucose metabolism and causing weight gain. And the health system, I think this is a great cause of concern, and which is why I titled my topic as what is the role of the psychiatrist in this. There is a fragmentation in the services between the primary healthcare and the mental health services. And there is a difference in the care that patients with mental illness receive for their physical health in terms of access, in terms of utilization, and in terms of quality of care. I must briefly take a small break here to tell you about the story of another of my patients who the previous day had distension of his abdomen. We did not know what was the reason, obviously, and he was also running temperature, so there could have been some kind of abdominal infection. So we sent him to a private medical college hospital. I'm not going to take names out here for obvious reasons. And this person was not seen by anybody over the course of the evening. They did not even do a simple, ultrasound of the abdomen to find out why his abdomen is distended. And the sorry state over and above that was the fact that he was given a double dose of his antipsychotic medications, put in one corner of the dormitory in that private hospital. He slept through the night. He got up. The duty doctor says, oh, he's fine, he can go home. He goes out to the reception and he drops dead there. No one has any clue what was wrong with him. And so it was like, you can imagine the mental health team's emotional status at that point, because we had no clue what was happening to this particular patient. So yeah, that's what I mean by the standard of care for the general medical conditions. The effects of stigma on the patient-provider interactions. There is diagnostic overshadowing. By this, I mean that, all that they had to do then was to do an ultrasound. He may have had a, burst appendix. He may have had any other reason for a distension of his abdomen, but no investigation was done. and actually that was a time when my interest in, many of these cases that I'm talking about were ones that actually stimulated my interest in physical health. The symptoms of mental illness actually can impose a challenge on accessing care and adhering to the recommended treatments for the physical health problems. And of course, the cost of care, lack of insurance, these are again important factors. I'm going to take you through one of our studies which we did in the outpatient. We just screened outpatients, about 450 people over a period of 6 months. Actually, all diagnostic categories, but given the nature of our services, majority was schizophrenia. Because they were on majority was schizophrenia, there were antipsychotics plus other medications in 68% of the population. And in 60% of that, this 450, the treatment was actually less than 5 years in duration. If you looked at the self-reported prevalence of diabetes, and we just asked them simple questions: are you diabetic? Are you hypertensive? Is there any family history of diabetes or hypertension? And we also looked at different risk factors. I'm not going to present the whole study here, but what we did was we just asked to this question on diabetes. So we had about 15.8% who actually reported that they had diabetes, and about 8.5% had diabetes and hypertension. But to the right side of the slide, you can find that the study identified as many patients at risk of hypertension with elevated BP as detected at SCARF as the number of patients who reported. I mean, 8.7 to 8.9%, which really means that there is a good number of people who are not reporting self-reporting the hypertension. So what is we also tried to understand what is the role of the psychiatrist. There are about, at that point in time when we did this study, there were about 10 psychiatrists and in the facility, including me. And the data showed that less than 20% of the patients with diabetes or hypertension were referred for further follow-up. Less than 8% actually treated but less than 8% of the population were treated for their physical NCD by the psychiatrist. So here was an opportunity and a need at a tertiary mental health center to have a defined referral pathway or an in-house expertise to manage the comorbid NCDs. When we actually reported these studies, there was a lot of discontentment amongst the mental health professional, simply because when you're seeing an OPD with 100 patients and you have to finish seeing them between 4 to 5 hours in the mornings, it's very hard to actually talk to them about diabetes, hypertension. Maybe if they're overweight, you might say, go do physical exercise, you might. But, our focus is so much on looking at the different range of patients that we really don't have the time to focus on the NCD component of our patients. I'm going to now take you through, again, another busy slide. But again, my point in putting up this slide is to just tell you about the drug interactions with the antihypertensive medications. So you have a group of drugs, the beta antagonists, which interact with drugs like chlorpromazine or thyroidazine and increase the plasma level of these antipsychotics. And you know what happens when drugs like chlorpromazine or thyroidazine are increased in the plasma? Naturally, the effect of there is also an inhibition of the antipsychotic metabolism, so that the drug levels go up. Then you have clonidine methyl-dopa, which again causes severe hypertension. You have the ACE inhibitors, which are incidentally the treatment of choice for hypertension, and they react with drugs like chlorpromazine, clozapine, and cause severe hypertension to the point of syncope. Calcium channel antagonists actually increase the concentration of antipsychotics in the blood, and there is an increased effect on the cardiac and the sexual functioning of the individuals. If you look at the right, the last fourth column, everything is saying hypertension, hypertension. So naturally, one is scared. When you want to treat hypertension in our patients, which is quite significant, there is this question in your mind: what is the anti-hypertensive that you can give this patient? And then finally, you'll end up referring them to your close friend who's a cardiologist. What happens then is another story. But then I'm also concerned about some conditions that can miss our eye. These are basically ECG diagnosis or echocardiogram diagnosis, and we have our molecules which are wonderful antipsychotics. I mean, many of us would actually swear by these molecules, quetiapine or clozapine, for drug treatment-resistant schizophrenia, but you do not know what is the effect that they are having on the heart of the individual in terms of QTC prolongation or in terms of cardiomyopathies over a period of time. Now, coming to the issue of diabetes, thankfully, the story is slightly different. Diabetes does cause a lot of cardiovascular complications, and I think we all know this from our clinical observations. Is there a link between schizophrenia and diabetes? Yes, it was demonstrated in the treatment-naive patients as early as even before 1976, but this was the published literature. And even one of our studies also actually, we demonstrated that in patients who were untreated, we were able to demonstrate diabetes. There's a lot of literature which goes into why you have this kind of a link, but I'm not going to go into that because I would like to keep it at a very practical angle. Diabetes and antipsychotics, I think that is another story that is quite popular. There's large volume of reports, yet that it could be an underreporting of the diabetes, because basically we are not testing enough people to be able to prove their diabetes. There is an increased odds ratio of diabetes with patients treated with clozapine in the first year. Increased risk of complications such as ketosis or acidosis or hyperglycemic episodes. These are something that are extremely important, and we have to pay attention to it. So, you would wonder, how do we actually find this out without doing any kind of laboratory? Sorry, you do need lab investigations to do this. But then sometimes we have found that, patients do get very angry and agitated, and there could be hyperglycemic episodes, and hypoglycemia episodes also seem to present with agitations in a few cases. And I think the story of weight gain is, again, not uncommon. This is something that we have to battle in and day out. Now, if you look at, very interestingly, there's been very little literature, very little interactions with the drug anti-oral hypoglycemic agents and drugs which we use for treatment of schizophrenia. But what is the risk of DM related with different, this chart will straight away tell you that one is the highest risk, rank order 1. So if you look at clozapine probably does the dirty job. I mean, using the word dirty job because, I mean, clozapine is such a wonderful drug, but we find that we have to monitor patients for diabetes or hyperglycemias, hyperinsulinemia, and so on, and the risk is quite high. With olanzapine too, the story is not very different. Risperidone, on the other hand, matches the conventional drugs. So probably in patients with diabetes, you might want to think of either an option of a conventional antipsychotic or a risperidone. So now let's try and look at what are the barriers in care for physical illness. I did mention a little while earlier at my hypertensive crisis when I found physical illness in a patient not attended to properly. So essentially, I think, over a period of time when you're, I'm sure Prabha will understand, and many of our senior, colleagues out here will understand, after 30, 40 years in the field of schizophrenia, sometimes, physical health of an individual does take a backseat. So we might be a little poor in identifying and treating medical disorders, physical health disorders, including cardiovascular disorders. Also, there's a increasingly strong evidence which suggests that at the health provider level or the system level, there is less access to sufficient health care. Twice as likely as those without mental disorders have been denied medical insurance because of a pre-existing psychiatric condition. In a primary care, people with schizophrenia are less likely to have a physical examination or to be assessed and treated for hyperlipidemia. Interestingly, SMI have more emergency department visits and experience avoidable admissions to hospital for physical conditions, which with appropriate primary care may not require inpatient treatment at all. Clinicians may attribute emerging somatic symptoms to the underlying psychiatric disorders, and therefore there could be misdiagnosis. And I used the term diagnostic overshadowing earlier. People with serious mental illness have difficulties in reporting medical complaints. I mean, we've had people with, like I told you about this coronary lady who had a coronary block. She actually didn't report pain for pain at all. She kept holding on to her chest, and that's when the family identified that perhaps there could be a cardiac problem, and that's how she landed with the cardiologist. Secondly, we have to interpret physical symptoms, and distinguishing them from the symptoms of their mental illness is another problem that we have to face. Staying engaged with psychiatric and primary care services. I mean, you have got to, if you have to go to two different places, then you might have a problem in remaining. So what is the responsibility of the psychiatrist? Can we make changes in our practice? Can we work with behavioral risk factors? Can we establish a referral pathway? So these are some of the issues that I personally feel we can actually do. So what do you do? One is, of course, there are no tools available to assess your lifestyle factors, and perhaps that is left to researchers amongst us who have to come up with this kind of a physical health assessment. And we are working. I mean, we are trying to adapt what the WHO has been talking about in their heart, this in a currently ongoing study. But I think the most important would be is to look at, these brief tools really need to be trans-diagnostic, right? Across the diagnosis of mental health problems and the physical health diagnosis we should be able to use it in various settings, even including a private psychiatric practice. We should be able to assess a range of behavioral risk factors and identify what is the key driver for physical health on a case-to-case basis. More efficient pathways should be provided for helping people with mental illness to overcome their behavioral risk factors, and that is specifically the multi-site study that we are currently on, and hopefully in a year or so we should have some data on that. We are developing a we have to be able to develop a multidisciplinary referral pathway, which looks at specialized physical activities, smoking cessation, access to a dietitian, and of course, enabling them to follow those things. Depending upon the individual specific behavioral profiles and health goals, we can have personalized lifestyle interventions. Within the broad category of integrated care, I think there's a lot of interest that's shown on the collaborative care model, which can perhaps reduce the, reduce the costs of care for the patient. So a core component of this collaborative care model is the involvement of several health professionals working together, which means a physician, a case manager, and a mental health clinician who can actually provide a structured management plan, a scheduled patient follow-up, and enhanced interprofessional communication, which is, I think, very, very critical for managing the physical health problems. So if you look at the WHO 10 progress monitoring behaviors, all these models, all these indicators can actually be applied to the mental health scenario as well. And really, the focus should be, in my opinion, on diet and physical activity, which is really doable, right? Reducing of unhealthy diet, in making sure that they are looking at improved physical activity. The harmful use of alcohol, we've not seen so much in our patients with schizophrenia, but yes, that's also an important indicator. And of course, we look at drug therapy and counseling for these high-risk people, not just for mental health, but also for their physical illness. So going back to my scenarios, what could we have done? In the first case, well, this person never woke up, right? So really, there's little much that we could do. But in the second case that I've said, definitely a lot of effort is now being, a lot of inputs are happening into her lifestyle. Over a period of time, she has lost a lot of weight. She, of course, can't give up on junk, but we are trying to work on that. We're trying to help the family not, look at too much of junk food. Thankfully, during the COVID period, the mother had to cook food at home. She's living with her parents right now because she was divorced from her husband. That's another story. However, the mother, because they could not eat food from out, the last 9 months has meant that she has had a lot of home cooked food. So hopefully her lab values are going to be, but we'll now have to persuade her to go back to getting an ECG done or getting her sugars tested. So I think we should end today by taking a pledge to pay attention to our physical health of persons with SMI. And with practice, I believe we can perfect this art. I thank you all for this listening, and I thank the CME committee and the South Zone, members of the South Zone Executive Council for providing me this opportunity to talk about something that is very close to my heart. Thank you.
Thank you so much, Dr. Padma, for highlighting many issues. I think you, highlighted one, of course, the prevalence of various conditions, focusing mainly on diabetes and hypertension as well as cardiac conditions. You also talked about tuberculosis, which I think is a very important comorbid condition, and discussed the concept of multimorbidity, which I know is a big there's been a lot of funding for research on multimorbidity and to come up with packages, treatment packages which can be delivered in primary care. And we hope that in the next couple of years, we'll get some answers. You talked about drug interactions. I think the important thing was you brought a certain human element to the whole presentation, because describing your patients makes all the difference, because each of us can remember one of your patients whom we had, who had such an outcome, because maybe something was missed, maybe we didn't pay enough attention to it, maybe the patient didn't talk about it, the physician or the emergency team did not pay attention. I think these are very common occurrences. And I think what you're saying is very right. The need for the psychiatrist to be a good physician first. And something that I always tell my students that, maybe a physician doesn't need to be that good a psychiatrist, but a psychiatrist needs to be a very good physician. We need to all remember our medicine all over again. And a simple thing like a QTC is such an important issue. Also, you brought out the challenges of discussing lifestyle issues with patients with mental health problems. It's not very easy. Something very simple like the canteen in Nimhans, for example, sells only the most high calorie, fatty kind of food. And any attempt of mine to change the menu in a place where patients eat has not met with any success, because they all get very, very high, like vadas and samosas. And, these are simple things which we can actually start in very early, but it doesn't happen. So I think these are, and people with mental health problems get, eat what is available, what is easily available. And it has been shown that the poorer the person, the lesser the socioeconomic status, the poorer and the unhealthier the eating habits, because they eat junk, they eat chips, they eat, those kind of foods. So I think there's a range of challenges which is not just medical, but is also social in its challenges for us as psychiatrists. And I'm really looking forward to that list which Dr. Padma mentioned, which we may have at the end of a year or so from the research studies, which each psychiatrist can have possibly. SCARF has been great in bringing about ideas. So something like that, if we can have another checklist of quick tick boxes which a psychiatrist can do in a busy outpatient to make sure that physical health problems are being handled. So with these two amazing talks, there have been quite a few questions. So I'm going to ask the first set of questions to Dr. Ramya. Dr. Ramya, there's been questions on, are there any recent developments on antipsychotic drugs for cognitive impairment in schizophrenia?
There is some studies, like there is nothing conclusive about it, but then antipsychotics which with selective serotonin receptor profile, agonistic action selectively on certain transmitters of dopamine, they have not so much of cognitive dulling as the other drugs. So I think some studies spoke about amisulpuride as a potential molecule, targeting as compared with other molecules. But there is a very recent drug called lumateperone, which was approved by FDA recently. But I don't think it is available in Indian market, or I really don't know, like, is it available for patient use anywhere else in the world? It is claimed to have a lesser cognitive effect. It is a recent development of antipsychotic drug with a broader receptor profile. The drug is called lumateperone, but then I mean, it is FDA approved for schizophrenia, but I don't think it is available in our Indian markets.
So the other question is recent antipsychotic drugs to improve cognitive function. So one is, of course, about, not causing cognitive dulling, but also we know that cognitive impairment is important in schizophrenia. So like for positive and negative symptoms, drugs to enhance cognitive functioning.
Drugs to enhance, I don't think they belong to the antipsychotic group per se, but there are some case series and reports examining the effects of drugs like memantine and donepezil, basically the cognitive enhancers which can be given alongside the antipsychotic medications. Do they lessen the cognitive effects? But I don't know whether antipsychotic per se can address the cognitive defects of schizophrenia as of now.
Yeah, I think there's only sort of one or two RCTs which have looked at the role of clozapine in cognition with mixed results. One particular RCT is actually found that is possibly the only drug where there has been some improvement in some neuropsychological functions. There is another question on the role of ketamine in treating treatment-resistant schizophrenia. Is there any evidence for using ketamine?
No, actually, ketamine is actually an NMDA receptor antagonist. So schizophrenia now we conceptualize as a condition with NMDA receptor hypofunctioning. So NMDA ketamine, when used, it can cause hallucinogenic states. It's because of its properties of NMDA antagonist per se. There is no role for schizophrenia in, no role for ketamine in schizophrenia, unlike depression.
Yeah, a very interesting question from Dr. Arvind. So the dopamine supersensitivity hypothesis, which is a very old concept, how does it hold in relation to the newer drugs? Like, are the newer drugs which are being developed or in the pipeline? I think you kind of alluded to it, that the drugs are not really looking so much at dopamine blockage, but at a whole other range of functions, including inflammatory modulators. So, but you want to do a quick response to that. Are people going in the dopamine direction at all?
The materials that I read through did not speak of the dopamine sensitivity. The primary focus was on the glutamatergic and the acetylcholinergic pathways.
And possibly anti-inflammatory drugs.
Yes.
Finally, one question on newer drugs with nicotine alpha-7 agonists in the management of schizophrenia.
Yes, I mentioned just a line in one of my slides. Alpha-7 acetylcholinergic receptor modulators, they have been studied, but it is in phase 2 and 3 clinical trials. So we'll have to wait for further evidence before they can be actually used. As of now, there are newer drugs in the pipeline, but nothing is as such available in the market, or nothing has got the stage of approval as of now.
Okay. Thank you so much, Dr. Ramya. There's been a lot of appreciation for your talk, so I must tell you that it was wonderful. And I move on to Dr. Padma. Padma, some of the questions which have come up is, can antidepressants be given to patients with schizophrenia who have metabolic syndrome? So what is the additive effect of the use of antidepressants in people with schizophrenia when they're already receiving antipsychotics?
Actually, much of the literature has there is really no contraindication for the use of antidepressants in persons with schizophrenia who present with depression. So, for example, an SSRI can be safely given, and of course, we do need to. And if they also have an NCD, in fact, their NCDs can improve. There's a lot of literature which talks about how sugar levels come down in patients with diabetes who are treated with antidepressants. That's another set of studies. But if they are given antidepressants and they are, of course, they're sick schizophrenia, they are antipsychotics, they require an antidepressant, and they're also diabetic. You can actually use their particularly SSRIs, because that might, one, reduce the level of sugars. Probably the patient compliance with the whole treatment of NCD and the and any kind of psychosocial interventions for schizophrenia can improve, because they are feeling much better because of the antidepressant medication.
Yeah, I think that's a very important issue, that once the mood improves, automatically probably
Yeah.
adherence to lifestyle situations improve, and then the role of management of diabetes also in depression has actually got a very strong association with diabetes itself. The second question is about something about gender and weight gain. So among the antipsychotics that you mentioned, clozapine, olanzapine, is there a gender difference in weight gain? Do women tend to gain weight more than men? And in which case, what would be, I mean, do you think that we need to avoid certain drugs in young women to avoid things like PCOD? Of course, valproate we know, but we're talking here about antipsychotics. So two questions. One is about the gender differences in weight gain, and then specifically in context of PCOD.
Yes, there is definite evidence now. There's a lot of evidence to indicate that women tend to, especially young women, tend to gain a lot more weight with drugs like olanzapine. At that age, possibly if they've not been too ill for too long, like for example, first episode psychosis, you don't expect them to be on clozapine. But olanzapine, yes, in a lot of cases, olanzapine seems to be the treatment of choice for the first episode of psychosis. And then 3 weeks down, 3 to 4 months down the line, you will find that the woman has put on, the young girl has put on about 5 to 6 kgs and is so bothered about the weight gain that she will actually give up on the antipsychotics. So I would rather, and I don't see this happening. There are young men also who do gain weight, but definitely you find that the weight gain is much more rapid amongst women. So in a sense, I would urge us to tread a little cautiously, especially where we are looking at treatment of first episode of psychosis. You might want, and the other molecule is amisulpride. I mean, there are lots of people who have, lots of clinicians, psychiatric clinicians who do prefer the molecule of, prefer amisulpride. But the weight gain is so cumbersome, so terrible for the young girl. And that actually, in fact, I must share the story of a young girl with first episode psychosis who was attending a FEP clinic. And within a period of 6 months, she had put on a lot of weight. She was, of course, I mean, I'm a little cautious, and I actually started her on risperidone and not on olanzapine, because young girl, I would prefer to go a little gentle there. With risperidone, and with just 2 milligrams of risperidone, the weight just went up phenomenally, and about 10 kilograms of weight was gained. There were, of course, other reasons for why she had gained weight, and her sugar levels also had shot up, and she's just about 22 years old, right? Which was like, very intriguing and very challenging, because now I had to pull her out of antipsychotics, determine why her sugar level. As soon as the antipsychotic was stopped, her weight also came down, and then she was diabetes sugar levels also came down. And we had to talk to her a lot about exercise and diet and so on and so forth. She belongs to a Sindhi family who was living for many years in Chennai. And naturally, the diet that was given in the house was a lot of fat food. And although it was not junk, heavy food was what was eaten at her home. So a lot of time had to be spent with educating the family on the dietary habits of this patient. Unfortunately, she relapsed, and she had to go back on the antipsychotic. I did try putting her back on haloperidol, good old conventional haloperidol, and but then because of the side effects, she couldn't tolerate that. So we have now come to an agreement that she'll go on a very small dose of risperidone, and there is a regular follow-up. But yes, with olanzapine, with clozapine, sometimes if it's required, with amisulpride, weight gain amongst women is quite high. And the issue of even PCOD, in fact, this young girl also had PCOD. So naturally, everything complicated in her case. She didn't get her periods, and that was causing her a lot of a lot of turmoil, and so she actually came. She was delusional. She said, I've not got my periods, I think I'm pregnant. And so, which is again, it was a challenge to the the psychologists and the case managers who were dealing with her, to actually, because she was calling them more often than calling the doctor, right?
Yeah, I completely sort of endorse what you're saying. I was just wondering, Dr. Padma, there are a few questions about, also a little bit about, are there any, so we all know how challenging it is to get patients to change their diet or even to exercise, forget patients, even generally it's so hard to change your diet and exercise. It's so much more easier to just say that, but it doesn't really happen. Are there any sort of recent advances in, understanding things like leptin, appetite, the chemistry of weight gain? Are there any easier solutions to weight loss, antipsychotic induced weight loss? There was a
There
lot
is
of
not.
use of topiramate at some point.
Yes, in fact, there's not very much literature pertaining to serious mental illnesses, but there's a lot of literature in the general population on physical activity, dealing with obesity, diet management, and so on. There's one lovely systematic review which was by Simon Rosenbaum, which talked about what are the different methods by which they can actually this. And one of the strategies that they have suggested is motivational interviewing for as a method for getting these people to comply with physical exercise. And our gold standard says 30 minutes of walk. Now it's about 45 minutes of walk 5 times a day, but you try telling that to even to the normal population. So I've changed my language, and I say, okay, just go out for 5 minutes, and then next time I tell them go out for 10 minutes. And it seems to be helping, because they'll say, no, I went out for a walk, and over a period of time they actually increase their walk. And I try and tell them how good they feel when they start walking better. And the other thing that we are trying to do is to look at the carbohydrates in the diet. It's like, it's very hard for people to actually, especially from the southern part of India, to say cut down on rice. It can be very traumatic to people. Even I think the bunch of us sitting here trying to cut down on carbohydrates, say don't eat so much of rice, it's going to be a challenge. But I try and tell them, like, instead of draw a small picture and tell them what could be the quantity of vegetables. Instead of saying reduce carbohydrates, I say increase on vegetables. But then we must also remember that many of the patients whom we are treating at SCARF come from a low socioeconomics. So buying vegetables today, the lady's finger was costing 100 rupees a kilo.
Exactly.
So potato was some 120 rupees a kilo or something. Forget potatoes. I mean, I'm sorry I brought that in. It's a carbohydrate. But looking at beans and carrots and things like that, that's so expensive that I can't think of, the common man really affording these kind of vegetables, which will replace their rice, right?
Yes.
So it is a challenge. But I think what I believe in is that you make them aware of it and try and see. The other thing that we have tried is regular monitoring of sugars. Of course, the sticks are quite expensive. The machine per se will be quite cheap.
Yes.
I mean, but the sticks are so expensive that's also another cost. But we try and manage how we can actually do that to integrate it into their day-to-day lifestyle, particularly if sugars are high, if blood pressure is also high and it's like a kind of a multi-morbidity situation.
There's another interesting question about risperidone. One, of course, is related to the role of risperidone and stroke, and what is the current, recommendation.
Yeah, so risperidone.
And a question about the fact that the use of statins with risperidone, which has been found to postpone metabolic disorders, and if you have any comment on that.
Yes, there is. I mean, unfortunately I've not done much of reading on that, but the little that I have read, there is risperidone is definitely indicated. Somebody with schizophrenia who goes into an intensive cardiac or has a cerebrovascular accident, or there is a cardiac, there is a medical comorbidity in such terms, definitely would prefer to have risperidone than any of the other antipsychotics. And co-prescriptions, I mean, if you look at the cardiologist prescriptions, you will definitely have a statin, because that's the gold standard right now. Everyone, there'll be an antihypertensive, there might be other kind of antiplatelet agents, and plus you have the statins. So what happens is adding a risperidone is much safer. There's a lot of literature which talks about that, which says that it's much safer than to use any of the other antipsychotics, particularly the atypical. So olanzapine and all, no. Preferably you look at risperidone. Of course, Q-tipin, we really don't know because QTC elongation is a big challenge. So you wouldn't think of a Q-tipin. But then again, I seem to tend to go back to our good old conventional antipsychotics. Why not the Serenase? Why not the, Serenase? Mostly it is the Serenase that I would prefer in such conditions. But yes, risperidone does have a role to play.
So the question also is whether can we, before the person develops a metabolic syndrome, is there a role of adding a statin to prevent metabolic complications?
No, there is no conclusive, there's no conclusive evidence that statins will work. Statins need to be used if there is an indication. If there is a cardiometabolic indication for the role of statins, because the side effects of, remember there was a period in which there's a lot of literature going, a lot of debate about withdrawing statins, even from the cardiologist's armamentarium, right? So of course now it's back that the guidelines do tell you that the statins are required, but I don't see the role for statins before it is indicated. To prevent a metabolic, the only way you can prevent a metabolic complication would be to, perhaps anticipate it, make sure that there is a lot of, make sure that you're watching out for it, and then if it happens, manage it early.
Finally, question on can we mute, please? Sorry, Padma.
Yeah, no problem.
I think the final question is about, the FDA has a warning that the chances of stroke is much higher with risperidone, and so they have issued a warning many years ago. Is there any Indian data which supports the fact that there is high incidence of stroke in people who are taking risperidone?
To be honest, no, I'm not really aware of such kind of information from the Indian scenario. And even if it is there, I think it would be very sparring because we don't really see it so often in the clinical setting. But whoever asked the question, I'm happy to respond to it. I'll probably go back, check it out, and then let you know.
Right. So thank you, Padma. I think there are a few other questions, but we are definitely running out of time. I've tried to look at most of the important questions. So thank you, Ramya and Padma, for that very fascinating
can I ask
discussion.
2 questions?
Yes.
Can I share my views?
Go ahead. Yes.
Yes, thank you. Short thing. Very good lecture by both the speakers. I like to share my experience regarding the metabolic syndrome and other things. I judiciously use metformin for people with, especially with clozapine and other things. That is one aspect which I judiciously use it. Many patients, though we diagnose diabetes and hypertension, though we refer to physician, they refuse to go. You yourself will treat. That's what people say. We cannot go to too many doctors. That's another problem that is happening even for physicians, and it is a thing. We have got an in-house physician. That is one thing. Even for the next room, they are not ready to go to the next room to see the physician. That is the state of our mentality of our Indian population. So what I do is I get the opinion from the physician and continuing for some time, and then repeatedly testing the blood level and other things. After that, and I send them for review. That is one aspect which I wanted to share with you. And regarding the inflammatory pathway and other glutamate pathway, which is Ramya explained very wonderfully, I like to say my experience with minocycline. Minocycline is actually, it is an AMPA, this one, but it works very well. I have seen a lot of people, especially, I'm very happy to say, one hospital, one company is sponsoring our Shantivanam patients, the home for homeless people. We have got 100 people there. Almost they are all chronic schizophrenia people. And with their acceptance, I am giving metformin, this minocycline to all patients. They are improving very well. compared to regular antipsychotics, adding minocyclines has a cutting edge. That's what I was able to find out. That is another my experience which I wanted to share with you. That's all, madam. Thank you.
Thank you, Dr. Ramakrishnan. I think, those are very valid points that patients do not want to go to another doctor, even in the next room. I think it's a very, very common finding that we have. So ideally, we need to be able to solve all our patients' problems as far as possible. Thanks for letting us know about minocycline. I just wondered, I have not used minocycline except in treatment-resistant schizophrenia, but one of the concerns is this hyperpigmentation, they say, of the skin. So how often do you find that happening?
Not very, because we are all
Anyway,
kind of
we have
just
hyperpigmentation.
colored. That's why there is not much difference about it. And even in my OP patients, I talk about the cost and give them. Many people say, sir, don't stop minocycline. Many follow up also. People say, sir, no, don't stop minocycline. People are telling like that. So even the family is able to understand some cognitive difference with addition to minocycline.
Thank you very much. So on that note, I am going to hand it over to the organizers to conclude the program. You will agree with me that this was a wonderful evening, and even though we have gone ahead of time, it was a very engaging and interesting program. So I thank the IPS South Zone to having organized this. Thank you so much.
260 people are still online. That is a record. Thank you.
Dr. Dayal, we can give the vote of thanks.
Good evening, respected President Dr. Ramakrishnan sir and other dignitaries of South Zone branch. It's my pleasant privilege to propose the vote of thanks for this exceptionally brilliant academic evening that we had on a very, very important topic close to all of our heart, all psychiatrists, schizophrenia. And on behalf of IPS South Zone branch and the executive committee and the CME subcommittee, and on my personal behalf, I take this opportunity to thank Dr. Ramakrishnan sir for actively coordinating and helping us through this very good initiative of academic nature, Vice sir. And I also thank Vice President Ramanan sir and all other executive committee members who have been helping us through this, organizing this program and making it a big success. Most importantly for this evening, the academic part of it was brilliantly moderated and chaired by Professor Prabha Chandra. I thank you, madam, for that very active role that you have taken in coordinating this session very smoothly and bringing out the academic points in a very, very beautiful way. Then our distinguished panelist speakers, Dr. Padmavati madam and Dr. Ramya, both of them, everyone will agree that they did a very brilliant job of elucidating those very difficult topics in a very clear and comprehensive way. And actually the clarity of their presentations was reflected in the type of questions that came up in the end, and the way in which they responded to those questions were also very, very brilliant. I thank each one of you sincerely for your active participation. I also thank all the senior colleagues and teachers, consultants, and my friends who have joined in good numbers and actively listened to the whole program throughout the session and made this a grand success this time. I again a special thanks to Dr. Aravind, who has been the man and the brain behind this academic program, who has taken all the pains in making sure that everything goes perfectly and smoothly, and also the other members of the CME subcommittee. And I also thank the sponsors for Sun Pharma for extending their help in supporting this academic activity. Once again, thank you all for joining us in this evening, and we also hope that we get such active participation in future sessions also in the coming months. Thank you all once again. Thank you.
Thank you, Aravind.
Thank you, sir. Thank you.
Thank you, Prabha Chandra madam. Thank you very much. Thank you very extremely thanks. Dr. Ramya, wonderful.
Thank you so much, sir. Thank you so much for this opportunity, sir. It was great to interact with people like you and to have your inputs. So minocycline, those points are beautifully brought up because there's no experience from my side, but then you beautifully brought out the experience from your end.
Now I am trying NSL 16 also. Recently I started trying.
Great, sir. Great, sir. Thank you so much.
Thank
for
you.
the
Thank you
opportunity.
so much. Yeah.
Thank you, Basmati madam. Thank you so much, madam.